Cirrhosis of the liver. Now this topic is very important. Already I have given you enough idea about cirrhosis of the liver. Am I right, my dear students? Yes. Do remember, it is the next stage of the hepatitis. When the patient of hepatitis do not recover, patient move to the next step, and that step is known as chronic hepatitis. The end of the chronic hepatitis is the cirrhosis of the liver. Hepatitis B and hepatitis C produces cirrhosis of the liver. Maximum patient of hepatitis C converts into cirrhosis of the liver. 50% of the patients of hepatitis B shows liver cirrhosis. Liver cirrhosis is also seen as a complication of alcohol. Alcoholic liver disease convert into cirrhosis of the liver. This is a very important thing. Many times told you, again repeating my words. Cirrhosis requires continuous consumption of alcohol. Cirrhosis requires continuous consumption of alcohol. The fibrosis is irreversible. Fibrosis in cirrhosis of the liver is irreversible. To remember, liver is the organ having highest capacity of regeneration. Even 15 to 20% of the liver, if alive, it can regenerate the whole liver. But very unfortunately, if the destruction of the liver is beyond that, then irreversible changes takes place in the liver. And that irreversible fibrosis of the liver is termed as cirrhosis of the liver. Cirrhosis of the liver is fibrosis of the liver, where the liver reduces in the size. Liver reduces in the size. And that's why he is checking his patient and telling him that you are having cirrhosis of the liver is nonsense. तपासून liver cirrhosis करणार नाही. Are you getting my point? Everyone is getting my point? Yes. It is the end result of the chronic liver pathology. It may be the end result of hepatitis B or hepatitis C, clearly told you. It may be an end result of alcoholic liver disease or maybe drug induced. Drug induced ला कंसात लगेच टाकून द्या methotrexate. Methotrexate. बाकीची पण आहेत, but methotrexate is dangerous. That we use in rheumatoid arthritis, that we use in psoriasis. Psoriasis मध्ये पण वापरतात methotrexate. And that's why it's common sense. If you are using it, use it. Don't worry about methotrexate use. But yes, after 1 month, go with SGBT. Check SGBT. If it is rising, then restrict the dose. Yes. Use with caution. Methotrexate, मी पण वापरतो. But use with caution. Yes. Weekly dose असतो methotrexateचा. Weekly dose असतो. It is irreversible liver injury involving mostly the entire liver. Agree with me? Initially inflammatory process followed by the destruction of the parenchyma and finally the fibrosis. Irreversible fibrosis of the lung parenchyma is equal to cirrhosis of the liver. Getting it? Yes. Common causes: chronic relapsing hepatitis B and hepatitis C, alcoholic liver disease, drugs like isoniazid, antitubercular drug, methotrexate, methyl-dopa is antihypertensive. Not much used today. Very old antihypertensive. Yes, but it is the safe drug during pregnancy. Methyl-dopa is safe during pregnancy. And that's why it can be used in pregnancy-induced hypertension. Valid use of methyl-dopa in the market today. Clinical features. Now this is very important. Your patient may present with nothing. Your patient may present with something. Your patient may present with serious symptoms. Anything is possible in cirrhosis of the liver. Yes, I told you that girl yesterday. ती मुलगी सांगितलं ना तुम्हाला इंजिनिअरिंगची, सांगितलं ना तिला काय वर्गात पडली, त्याच्या आधी 6 महिने आली होती माझ्याकडे मेन्स्ट्रुअल इरेग्युलरिटी म्हणून. वर्गात पडली, चेक करायला गेलो आम्ही, USG केली तर काय आलं, सिरोसिस. देन आम्ही मग हेपॅटायटिस बी बघितला. पेशंट मे प्रेझेंट एनिथिंग. वीकनेस, loss of appetite, getting my point, can be a sign of hepatitis. Let us see. Weakness, fatigue, muscle cramp, weight loss. Muscle cramp can be a sign of hepatitis? Yes. Getting it? Yes. सगळ्यात महत्त्वाची गोष्ट लक्षात ठेवा, मोस्ट इम्पॉर्टंट इज appetite. Appetite. पेशंटला भूक लागत नाही आहे, the patient is not having will to eat, then it is a serious problem. And when it is happening in Bevda, that is most serious problem. Getting my point? Yes. GIT symptoms include anorexia. Just 2 minutes back I told you about. When the patient is not having will to eat, that will is very important. That is anorexia. Nausea, vomiting, gaseous distension of the abdomen. When the whole process of digestion is disturbed, the GIT flora also get disturbed, and that is being producing the gases and all that. You should remember about that thing also. Early stage shows hepatomegaly, hepatitis, followed by the shrinkage of the liver, and that is the real cirrhosis. Cirrhosis of the liver. Getting my point? Jaundice. In what happens in jaundice? Sorry, is there jaundice in the cirrhosis of the liver? Yes. How much jaundice will be there? How much jaundice is there? It is always moderate. It is not much jaundice. 4, 5, 6 बिलिरुबिन असेल. असं नाही होत 24 बिलिरुबिन झालंय. प्रोडक्शन पण होत नाही ना बिलिरुबिनचं. It is evident that bilirubin rises and the liver is unable to conjugate the fat-soluble bilirubin to water-soluble bilirubin. In early stage, as most of the liver is collapsed, very late stage, production of bilirubin itself has reduced, and hence only moderate rise in the bilirubin is observed. Are you getting my point? Yes. Ascites. Yesterday I spent good time telling you about ascites. Ascites. Why ascites develops? Yes, there is total collapse of the architecture of the liver, and that's why the blood coming from the GIT cannot be received by liver. Liver is receiving lesser blood because of the pathology inside the liver, and that's why the blood accumulates in the portal circulation. And that blood is having lesser amount of proteins. Why? Because already liver is ill. Liver is the biggest site for synthesis of proteins. But the proteins are not available. Because liver is ill. Now, there is congestion of the blood in the portal circulation, having lesser number of proteins in it, and that's why plasma moves out. And this is the reason the plasma is oozing out from portal circulation. That will accumulate in the peritoneum. And this is how, my dear student, the fluid accumulates in the peritoneum. And that is what we call ascites. That is what we call ascites. My point is very important. When this ascites starts, with a minor collection, you may not be able to detect it. But as the collections start increasing, the first sign you will get everted umbilicus. Your umbilicus is inverted. Your umbilicus is inverted. It is going inside. बेंबी जर आपण व्यवस्थित बघितली ती अशी गोल फिरून आत गेलेली असते, तुमची माझी सगळ्यांची. ह्या लोकांचं काय होतं, ती गोल फिरून अशी बाहेर येते. बल्जिंग यू विल फाइंड देअर. And if I am there, I will find only that sign. मी बाकी काय फारसं बघणार नाही. मी काय बघतो, umbilicus. So that umbilicus will give the idea, everted umbilicus will give the best idea that yes, ascites is there. And this is so excellent that you see it, you diagnose it. You just see it, you diagnose it. Yes. Love at first sight sarkha. You just see it and you diagnose it, ascites आहे. प्रथम तुझ पाहता. Ascites, it's very common in the cirrhosis of the liver. The site of production of protein in cirrhosis, protein synthesis is reduced and hypoproteinemia develops. Due to hypoproteinemia, ascites develops. Not wrong, but this is not the only cause. Second important cause is portal hypertension. Portal congestion and portal hypertension. Portal congestion, portal hypertension and hypoproteinemia all together are responsible for ascites of cirrhosis of the liver. Am I right, my dear student? Portal congestion is also an important cause of ascites. लिहिलंय खाली लिहिलंय, मला वाटलं मी नाही लिहिलं. Circulatory effects, very important topic. As the cirrhosis of the liver cannot take the blood from the portal circulation. Portal hypertension develops. Caput medusae related with the veins. Spider nevi related with the arteries. Esophageal varices. I have explained this esophageal varices very earlier. Lower end of the esophagus. You will get bulging. Why? Because it is the portal circulation do not have walls. Portal vein is full, is not having any walls. Portal circulation do not have walls. Portal circulation do not have walls. Caput medusa, then spider nevi, esophageal varices, hemorrhoids are the important manifestations of this. Already I talked to you about, I will show you the pictures. Caput medusae, spider nevi, esophageal varices, already explained, and hemorrhoids. See, mechanism of esophageal varices and mechanism of hemorrhoids is the same. Where are the hemorrhoids, my dear student? The hemorrhoids are in the rectum. Point is important. This is the anorectal ring. This is the buttock. Getting my point? Here is the bulging. Bulging of the veins because the pressure is here. Not here actually. The veins are like this, erect veins are there. But veins are not able to carry the blood to the liver. Am I getting my point? Now I am asking you one very important question. How are the esophageal varices? Esophageal varices are like this. It is same as thus. Getting my point? Yes. Here is again the problem. The veins are erect. And that's why bulging takes place at the end. Because they don't have wall. Wall असते तर असं झालं असतं का? नाही. Now I am asking you a very simple question. Esophageal varices, I have shown you. And this is hemorrhoids. They are having similar pathology. How is the chance of development of these esophageal varices against the chance of development of hemorrhoids? I am just asking you, which is more common? Hemorrhoids is more common. In case of cirrhosis of liver, I am specific to the disease I am talking, whether there is more chance of development of esophageal varices. or there is more chance of development of hemorrhoids? The answer is esophageal varices. Because the blood which is trying to bulge in the rectum is having much chance to accommodate. Are you getting my point? अरे स्मॉल इंटेस्टाईनची लांबी किती आहे? 6 मीटर. ते बल्ज होताना मला काय म्हणायचं तर लक्षात घ्या, त्याला लपायला जागा बरीच आहे. त्या व्हेनला अकोमोडेट व्हायला, ब्लड अकोमोडेट व्हायला चान्स बराच आहे. तसं इसोफेगसचं नाही, इसोफेगसची जागा एवढीच आहे. याच्यातच त्याला अकोमोडेट करायचं आहे ब्लड, आणि ते नाही होतं त्याच्याकडून. त्यामुळे हे लवकर बल्ज होईल. खाली रेक्टमच्या वेळी रक्त जमेल हे मान्य आहे मला, पण त्याला लपायला जागा भरपूर आहे ना. ही जागा छोटीशी आहे ना बाबा रे, पूर्ण इरेक्ट आहे ही जागा. त्यामुळे इथे काही प्रॉब्लेम झाला म्हणजे इकडे लिव्हर जर घेत नसेल तर रक्त इथे लगेच बल्ज आउट करेल व्हेनला. whereas rectum is very much far away from the liver. That's why that vein is also very big vein. It is having chance to accommodate. And that's why hemorrhoids are not seen in every patient of cirrhosis of the liver. In 50% of the cases, you may see hemorrhoids. But esophageal varices are almost seen in every patient. Are you getting the point? Are you getting the logic behind that? लिव्हर पासून ॲनसचा पार्ट, रेक्टमचा पार्ट बराच लांब आहे. त्या व्हेनमध्ये ते ब्लड अकोमोडेट व्हायला चान्स मिळतो आहे. कळतं आहे का मला काय म्हणायचं आहे? तसं इकडे नाही आहे. इकडे हे अगदी सरळ आहे. इथून जर नाही गेलं तर ते इथे आलंच म्हणून समज, फुगलं म्हणून समज. आणि म्हणून इसोफेजियल व्हरायसेस आर मच मोर कॉमन दॅन हेमोरॉइड्स. Hemorrhoids are seen in some patient. The pathology is the similar pathology. Pathology is the similar pathology. Now I will show you the caput medusae. What is this? These are the prominent vessels over the abdomen. Why they are becoming prominent, my dear student? Very simple. The portal veins are having congestion, liver is not receiving, and that's why the portal veins are trying to find a way how to take the shunt to the systemic circulation. This is an attempt, very clear, very clear. The attempt of the vessel, that is what? Portal veins, to attach somehow to systemic circulation is in the form of bulging of the veins. They are trying to develop collateral circulation. They are trying to develop collateral circulation. And because of that, you find this caput medusa. Medusa or medusae, whatever you like. The veins on the abdomen become prominent and hence can be easily seen per abdomen. It is due to the development of collateral vessel. It is actually the try to develop collateral vessel. It is collateral circulation. It is an attempt of the body to develop collateral. Excellent. Can you see? विचारच नाही करायचं काय. असा इट इज. अरे याच्यात काय शोधतोय लेखा? हे काय सगळ्या व्हेन देखील लेखा. सगळ्या व्हेन दिसून राहिलाय मला. हे काय चटका बिटका दिला असेल त्याला. गावाकडचे लोक काही प्रयोग करत राहतात. आर यू गेटिंग द व्हेन्स? कॅन यू सी दिस? Everted umbilicus. Excellent everted umbilicus is there. No need to think even. So excellent. Happy? Now the next. Now I should tell you first the story. What happens in this ascites? A central vein, central artery dilates. Central artery dilates. And the radiating part around it also dilates. it looks like this. Spider. This is arteriolar dilation. My point is very important. Caput medusae is related with vein dilation. It is the dilation of the veins which I have shown you. I had shown you just. This is arteriolar dilation. Getting my point? Now I am going to show you. Spider nevi, the development due to the dilation of the capillaries around the central artery. It is common in the hepatic cirrhosis. Yes, this is also important. Palmar erythema, मी बोलणारच होतो आता. Palmar erythema is also same. पिन कामाने हात लाल पडतात. हां, that is a sign of cirrhosis of liver. Palmar erythema is a sign of cirrhosis of the liver. Now I am going to show you how it looks like. Can you see, my dear students? Can you see it? Something is there. Dilation is seen. Now I am showing you the next. Next is very excellent. Wow. Can you see it? हे एकदम टिपिकल स्पायडर आहे कडे. स्पायडर नेव्ही काखेतला पिक्चर आहे ते. व्हेरी एक्सलंट. बॉडीवर कुठेही सापडू शकतं, पण दिस इज अ साइन ऑफ सिरोसिस ऑफ लिव्हर. हे कुठलं आहे पण हे आर्टेरिओलर डायलेशन आहे. दिस इज आर्टेरिओलर डायलेशन. अर्लियर वॉज व्हीनस डायलेशन. स्पायडर नेव्ही इज आर्टेरिओलर डायलेशन. कॅप्यूट मेड्युसी is a dilation of the veins. That is the important difference every student should know. Are you with me, my dear student? Esophageal varices. तुम्हाला गंमत म्हणून सांगतो, आम्ही सकाळी या गणिताने गेलो की आज हे शोधू, हे शोधायचे. गंमत सांगतो तुम्हाला, दुपारी 1:30 वाजता आम्ही निर्णय घेऊन टाकला होता की हा बाबा घ्यायचा, आणि दुसऱ्या दिवशी सकाळी 10 वाजता त्याचं पेमेंटही करून टाकलं. त्यालाही शॉक बसला तिकडे. काल कोटेशन दिलं, काय घासागी जावं, काय ह्याची घासागी झाली, चांगलं प्रोडक्ट आहे, चल देऊन टाक. या काही 1 रुपया पण नाही कमी करायला लावला मी त्याला. 1 रुपया पण नाही कमी करा. मी सांगितलंही म्हटलंही नाही त्याला की कमी कर. का बरं? अरे प्रॉडक्ट चांगला आहे, मला शिकवायचं पोरांना, सर बाकी सोड. Varices. They are the result of portal hypertension. The esophageal vessels are erect and become tortuous. He said we have spent good amount of time telling you all these things. Am I right? Yes. When the corrosive food passes from it, it bursts and fresh hematemesis develops. Do you agree with me? Then the next comes hemorrhoids. Hemorrhoids, the same way. As a part of portal hypertension, the blood returning from the rectum cannot be received by the cirrhotic liver, and hence bulging of the veins of the rectum take place. It is known as hemorrhoids. Am I right? The pathology for the esophageal varices and the pathology for the hemorrhoids is the same. Only thing is that much space is available for accommodation for the rectum. The veins are long, and that's why much space is available, and that's why development of hemorrhoid is not so common as the development of esophageal varices. Am I right, my dear students? Now, endocrine changes. Loss of libido, development of breast, that is gynecomastia in male, testicular atrophy. All these changes are seen in male. In female, exact opposite to it is breast atrophy, amenorrhea. And if you think properly, it is related to the degradation of the hormones. Liver is the only site of degradation that is having some issue, and that's why there is some hormonal imbalance. That is what I can use the word. You may be thinking, sir, how? Do remember one very simple thing. These all hormones are produced from cholesterol basic molecule. That cholesterol converts to prognolone. Prognolone. पूर्ण नाव आहे त्याचं. And progesterone get converted to progesterone. Progesterone get converted to testosterone. And testosterone further get converted to estrogen. BAP is estrogen. Last is estrogen. But this is not the only serial one. They may convert intermittent also. And one molecule cut, OH group addition will give you the new molecule. And that all function has to be done by your liver. If liver is not doing it well, then there may be some hormonal imbalance. And this is the result of that hormonal imbalance. Getting my point? Because liver is the biggest site for degradation of all steroids. If the degradation is not happening well, a molecule can be converted into another molecule because of that bad destruction of the, not proper destruction of the molecule. Loss of libido, loss of axillary and pubic hairs, testicular atrophy, gynecomastia in male, breast atrophy, irregular menstruation and amenorrhea in females. In most of the time, females are the victims of that hepatitis B or hepatitis C. In male, the common is very unfortunately ALD. आपल्याकडे जे पेशंट सापडतात त्यात स्त्रीला जर असेल सिरोसिस तर तो बहुतेक वेळा हेपॅटायटिसचं कॉम्प्लिकेशन असतं आणि पुरुष असेल तर दुर्दैवाने ते बहुतेक वेळा अल्कोहोलिक लिव्हर डिसीजचं कॉम्प्लिकेशन असतं. बहुतेक वेळा, नॉट नेसेसरी ऑलवेज. येस, देर आर केसेस ऑफ कॉम्प्लिकेशन ऑफ हेपॅटायटिस बी, कॉम्प्लिकेशन ऑफ हेपॅटायटिस सी, but if you compare it with alcohol, alcoholic cirrhosis is most common. Infective hepatitis converted into cirrhosis is also there, but the cases are less as compared to ALD, alcoholic liver disease. ALD is dominant cause of cirrhosis of the liver than infective hepatitis. Infective hepatitis dominates in female. आपल्याकडे बायका इतकी दारू पित नाही की ते सिरोसिस होईल. बेवड्या झालेल्या नाही आहेत फार. आता होत आहेत हळूहळू, त्यांना सुधारणा म्हणतात. काय कुठं काय सुधारतात मला काय कळत नाही. हां, दारू पिण्याचं प्रमाण मुलींमध्ये पण वाढत आहे. हे हल्ली काय ते पागल झाले सगळे. स्पॅनोमेगाली, it is commonly observed with almost every patient of cirrhosis of the liver. Splenomegaly is a feature of cirrhosis of the liver. Hemorrhagic tendency. This is a very important thing already discussed with you. Hemorrhagic tendency is found. Do you agree with me? There are two important components. One, liver is ill. That's why synthesis of clotting factor will be difficult because every clotting factor is almost a protein. Some major clotting factors are synthesized by liver itself. And that's why if the liver is having the disease, then production of clotting factors will be a problem. This is one thing I told you. Second thing is more important, that is maturation of clotting factor require vitamin K. Vitamin K is produced by gut microbiome. The activity of gut microbiome depends upon the hepatic function, actually the digestion. When the digestion is not proper, the gut flora will get disturbed. When the gut flora is disturbed, production of vitamin K is not proper. Do remember, you get vitamin K from outside also, but that is not a main source of vitamin K. Main source of vitamin K is internal. Are you getting my point? It is due to the reduced production of clotting factors by the liver. It produces epistaxis, purpura, etc. Vitamin K deficiency is also important factor responsible for hemorrhage. Am I right? Getting point? Both the points are there. Points are important. Point 1, clotting factor. Point 2, vitamin K. Both are interrelated. Both are interrelated. And that is the reason, my dear student, during the treatment purpose, we give vitamin K. Injectable vitamin K is given. Injectable vitamin K is given. Hepatic encephalopathy, a very important part I am going to discuss. colonic bacteria are responsible for this encephalopathy. Normally, in the gut, ammonia is being produced. In all you, me and everybody, the colonic bacteria are responsible for production of this ammonia. In all of us, ammonia is being produced. सगळ्यांमध्ये आपल्यामध्ये ammonia असतो. Very immediately, this ammonia is get converted to urea and liver is responsible for it. Liver is responsible for it. Liver converts ammonia to urea. And urea, all of you know, it is excretable. And that's why a simple thing happened. Am I right? Now my liver is having the problem. Liver is having the problem. Liver is having the problem. What can be done? The conversion of ammonia to urea will not take place. The level of ammonia in the blood will rise. This ammonia is very toxic to the brain. The very bad thing is that it can easily pass the blood-brain barrier. It disturbs all major functions of the brain. The blood ammonia level rises and patient will go into hepatic encephalopathy. First, the patient may not be able to recognize the doctor. Slowly the level of consciousness also reduces. And after some time, patient will pass into hepatic coma. Means patient is sleeping, but that is not arousable. In simple language, patient is sleeping, but that is not arousable. Level of consciousness is decreasing and level of ammonia in the blood is increasing. Am I right? Now this fellow is thinking, Dr. Joshi, what to do? What to do? Who is responsible for this ammonia? Gut bacteria. Kill them. How? Neomycin. Use neomycin. Neomycin is an aminoglycoside. Only aminoglycoside given by oral route because it is 100% not absorbed and it is useful for gut bacteria only. It is known as gut sterilizer. Neomycin is well known by the name gut sterilizer. It kills the microorganisms there. When the microorganisms in the GIT will be killed, the production of ammonia will drop out. Am I right? When ammonia will be reducing, whatever is present in the blood will be eliminated by liver slowly. And this is after 2-3 days. The level of ammonia will be coming down. And this is how the patient will get consciousness. Am I right? Yes. Ammonia is the crux. Ammonia is the crux. Hepatic encephalopathy. Hepatic encephalopathy is a late complication. Agree with me? Colonic bacteria are producing the ammonia which cannot be taken up by the liver, cannot be converted to urea. Very simple. This ammonia is toxic to the brain and is responsible for hepatic encephalopathy. Very clearly told you. Now, purposely I kept this picture so that my student will understand what exactly a cirrhosis means. What exactly the cirrhosis means. This is all fibrous tissue. And the size you can very easily compare. Size of the liver reduces. You cannot diagnose by checking the patient and don't diagnose in that way. Cirrhosis of the liver is diagnosed only with USG. Sonography is the only thing that will tell you, yes, it is cirrhosis. Hope so, my dear students, you are getting the point. This is again cirrhosis of the liver. Very easily one can diagnose it. Cirrhosis of the liver on the scan will be seen like this. This is the cirrhotic liver and this is the scan picture. That's why I put it there. How the scan picture looks like. We can very easily see the things over here. Am I right? General things I have added here. Yes, a tumor is there. A tumor is there. This is again a tumor. Two tumors are there in this. Spleen is big. Splenomegaly you can say. Metastasis. Wow. Nodular liver. This is the nodular liver. On scan. Perfectly. काय म्हणजे डोक्याला तापच नाही आहे. Nodular liver looks like this on scan. ते बघितलं होतं ना आपण तपासून. This is the nodular liver on scan. The pictures are so clear. मला असं वाटलं की पोरांना दाखवावं. Investigations, hemogram and ESR. Hematological derangement is a feature of cirrhosis of the liver. Hematological derangement is a feature of cirrhosis of the liver. And that's why HB is low. किती असेल? 6, 6.5 will be the HP. 6, 6.5 will be the HP. Am I right? Yes. Lymphocytosis, raised ESR. Lymphocytosis. It's a chronic inflammation in that way. In that way, cirrhosis of the liver is a chronic inflammation. SGPT, SGOT will be raised, yes. Bilirubin will be moderately raised, already I talked to you. Serum proteins will be decreasing. Hypoproteinemia is a feature of cirrhosis of the liver. Actually, we have seen all those things earlier. I'm just repeating in one way. Am I right? बघितलं ना आपण हे सगळे markers. CTBT काय असेल? वाढलेला असतो, वेळ वाढलेला असतो. CTBT will be increased because there will be, what is the problem? Clotting issues. Clotting issues, both in vivo and in vitro. I told you what is the difference between CT and BT. RFTs is not a main thing, but just remember due to ascites, low urine output is there due to ascites. That is a complication of ascites. Blood ammonia levels are very essential when the patient is comatose or is in hepatic encephalopathy. When the patient cannot maintain his, what I can say, level of consciousness properly, can identify individual, level of consciousness is going down, then the first target is ammonia. Check ammonia repeatedly. Ammonia levels must be checked repeatedly. Ultrasonography, USG. If required, FNAC. Actually, if you are there and cirrhosis is there in a hospital, then generally FNAC is performed. Fine needle aspiration cytology will be performed. Tapping of ascitic fluid is again a common thing. For diagnostic purpose is not important, but therapeutic purpose it is important. Because unless you remove that fluid, the breathing issue of the patient cannot be solved. भयानक दम लगतो पेशंटला. Getting my point? Yes. We have to remove it and we have to arrest its recurrence. How can you arrest? Increase the protein content of the blood is the only option. Now, treatment depends upon the condition of the patient Lactulose. Now my points are very important. Ensure 2 to 3 loose motions to the patient. That is a dose of lactulose. It may be 10 ml, it may be 20 ml, it may be 30 ml. Ensure 2 to 3 loose motions to the patient. By the way, what is this lactulose, my dear students? It is a laxative. It's an osmotic laxative. I should tell you, it's an osmotic laxative. What does it do? When you take lactulose in the intestine, it sucks the water from the blood and increases the watery content of the intestine. And this is how it helps to reduce the ascites. Are you getting my point? Yes. And that's why this is the preferred laxative used during the patients of this cirrhosis of the liver. 2 to 3 loose motion should be ensured. The dose should be adjusted according to this need. Yes, generally 20 ml is okay, but you may require little more than that. Generally preferred as 2 to 4 TSF twice a day. 2 minutes back I told you 20 ml. To control the gut bacterial flora and production of ammonia, we are going to use neomycin 500 mg OD. Neomycin is from the group of aminoglycosides. It is not absorbed from the GIT, and that is the reason why we are giving it. It is not absorbed from the GIT. It's a gut sterilizer. This is the only aminoglycoside available in the form of tablets. Neomycin is the only aminoglycoside available. Neomycin is available by the name neomycin only. Now this is again important. Lacilactone. Lacilactone tablet. What is it? It is spironolactone plus furosemide. Furosemide is a high ceiling diuretic or loop diuretic. And spironolactone is a potassium sparing diuretic. Spironolactone is a potassium sparing diuretic. It is generally used for maintenance of diuresis so that ascites should not develop again. Once you remove, we try to maintain it with lacilactone. It's a very famous drug for it. The furosemide is a high ceiling diuretic having the common problem of loss of potassium. And this spironolactone is there, which is going to control that potassium loss. It's a potassium sparing diuretic. It spares, it retains potassium. Spironolactone retains potassium. And second and the important thing that I am going to tell you now, spironolactone is an antagonist of aldosterone. Pharmacologically, my sentence is very important. Spironolactone is an antagonist of aldosterone, and aldosterone levels are always high in cirrhosis of the liver. And that's why you can block the retention of sodium and water by giving this spironolactone. Because all of you know aldosterone is a strong chemical. Aldosterone is amylocorticoid. It retains sodium and water. The antagonist of aldosterone is spironolactone. And that is the main role of spironolactone here, why we use spironolactone only. Then he is thinking, sir, I want to use amiloride, triamterene. Amiloride and triamterene are only potassium sparing diuretics, but those are not having the antagonistic activity for aldosterone, and that's why those are not preferred in this situation. This is very important. Actually, activity of amiloride and activity of triamterene is also very nice. but they are not the antagonist of, because we call them non-hormonal potassium sparing diuretics. But here we want hormonal potassium sparing diuretic. Getting it? Yes, and that's why spironolactone is preferred. That's why spironolactone is preferred. Injection Caplin, 10 mg per ml as 1 ml ampule, very alternate day or every day to control the bleeding episodes. See, depend upon the condition of the patient, you may require it once in a week, 3 days in a, once in 3 days, or you may require it daily when the patient is comatose. Getting it? It depends upon how much gut flora is working. Getting my point? Yes, it's a supplement. Na? Antibiotics are generally given to reduce the load. It's a general thing, because these patients are having low defense. These patients are having low defense, and that's why it is advisable to give antibiotics to the patient. Yes, you can use any of the drug, you can use fluoroquinolone. This is levofloxacin I have written. Fluoroquinolones should be preferred. Example, Glio. Glio म्हणजे levofloxacin. Levofloxacin, OD, for 5 days. Intermittent antibiotic use is compulsory, because the patient is highly susceptible for infections, and you need to use a broad spectrum antibiotic. Quinolones are safer by all the ways. Many ways they are safer, and that's why I'll prefer to go with quinolones. Hepatic encephalopathy, bowel wash daily should be given as it reduces the ammonia levels. Bowel wash काय करतात? Enema द्यायचा. What is the role of enema? See, ammonia is being produced in the GIT. When you give the bowel wash, what will happen? The ammonia will pass. Instead, that would have absorbed in the blood. नाही समजलं? जो अमोनिया तयार झालेला आहे तो रक्तामध्ये असा शोषला गेला असता. त्याच्याऐवजी आपण काय केलं? तर पेशंटचे बावेल्स ओपन केले, इनेमा दिला त्याला. इनेमा दिला तो सगळा अमोनिया बाहेर पडला. गुड. आर यू गेटिंग माय पॉइंट? कामली तू विरेचन नाही. याला काय द्यायला पाहिजे? विरेचन द्यायला पाहिजे पेशंटला. मॉडर्न मेडिसिनमध्ये पण तेच करतात. होप सो यू आर गेटिंग माय पॉइंट. Plasma albumin may be needed, should be given by the parental route, 20% 100 ml. Actually 20% 500 ml is also available. Aminocore is a trade name, or others are also available now. Yes. Albumin, plasma, ready-made albumin is available. Plasma albumin. Getting it? Yes, put it there. Human albumin. Synthesize human albumin. Thank you.